and then it goes into a hypothyroid state until the thyroid gland can get back to working, okay? And for some people, they stay in that hypothyroid phase forever, okay? Let's see. Yeah, we talked about all this last time. So here are our different types. I'll go back to my laptop so we have to adjust it a little bit. All right, so we're going to go through each one of these, and there's a lot of overlap. And by the end, if you were given a case, you'll be able to differentiate it on an exam, okay? So first and most common is your Hashimoto's thyroiditis, right? We already know this. This is the most common cause of hypothyroidism in the United States for adults and for kids. What's the most common cause of hypothyroidism worldwide? Iodine, right? Yeah. But U.S. It's Hashimoto's thyroiditis. Affects women much more than men, so that goes along with an autoimmune disorder and kind of thyroid disorders in general. Family history, definitely we see patients with a strong family history component, but it's not required. And then we already talked about subclinical. But a lot of times these subclinical patients will transition into Hashimoto's over time. And as mentioned with the silly diagram, when I talked about hypothyroidism, this is an autoimmune, so it's lymphocytes infiltrate into the thyroid gland, and they cause that destruction. And so essentially the thyroid is not able to keep up with the demands of the body. Right? So how do we do that? We give them one. Levothyroxine. Give them what they're missing. And then these people, if you did do an antibody panel on them, the vast majority you would see positive antibodies, right? Because it's autoimmune mediated. Typically TPO, but you can see any variation of the three. Any questions on that? So other causes, obviously iron deficiency. If you have a person with a kid or adult and they have a history of head or neck radiation, that should be a red flag that thyroid. Yeah, go ahead.
I'm sorry, guys. So this one looks like actually infiltrate the gland.
Yeah.
The antibodies are actually occupying.
So it's autoimmune mediated, but it's lymphocyte infiltration is the cause of that.
Thank you.
Yeah, you got it. So again, it's autoimmune mediated, but if you have a personal history of any kind of radiation, that's a dead giveaway that maybe something's going to happen to this thyroid. Okay, that's all I really need you to know. And then obviously at the bottom, it's going to coexist with other autoimmune disorders. So if you people with type 1 might also have thyroid disease, right? Lupus, and that's also probably the correlation with celiac disease. Signs and symptoms. We know the clinical presentation, right? That metabolic hormone has been turned down, so it's all those hypothyroid or hyperthyroid clinical presentation. And how they present in that hypo or hyper state is based on the T4. Okay. So again, these guys are going to have it's this variable hyperthyroidism. So most of the time they don't come in for the hyperthyroid because it's kind of mild. But if they do come in, they're going to have a tremor, tachycardia, feeling restless, right? Most of the time, they're going to come in when they're tired, they're fatigued, they're gaining weight, they're constipated, right? So typically, you see them in the hypothyroid state, but you could see them in either. Questions on that? Physical exam varies. Obviously, these people can have goiters or just have a normal thyroid exam. Labs, you guys know this, right? So if they're in that short variable hyperthyroid state, their labs are going to indicate hyperthyroidism, right? But it's not going to be like the same as a Graves patient, because in the Graves patient, that T3 is going to be really high. Because what's happening in Graves is these autoimmune receptors are kicking up excess T4 and T3 production, right? In this, the T4 is high only because of what's been passively released. Okay? And then again, it says that right there. Many patients won't present in this state. What you're going to see more often is this hypothyroidism, so high TSH, low T4. And if you do the antibodies, they're going to be positive. If they do, they're really in tune with their body. They come in that variable hyperthyroid state, and it's pretty mild. You could do symptomatic treatment, but usually they don't need anything, because again, usually they don't come in. But if they have clinical hypothyroidism, levothyroxine. Right? The duration varies. Over 90% of these people will be on levothyroxine lifelong. It's 11% they say will go into remission. We don't see that a lot in clinic. But yeah, majority will have to be on levothyroxine. And you can get a goiter in hyper or hypo. The goiters for these patients, it's because of that continual TSH stimulation from the pituitary. So the pituitary is working fine. The problem is primary, right? And 30% of people will have a decrease in that goiter after treatment, which is pretty cool. Any questions on this? The next one is all very similar, except for it's in the name. Autoimmune postpartum thyroiditis. So we have the patient population right there, right? Recently had a baby, and it can happen anywhere between like right after delivery all the way up to 1 year, okay, postpartum. And it's the exact same process. You have this release of stored T4, followed by, so you have this variable hyperthyroid state, followed by a hypo. When do you think that a female comes in? Hyper or hypo? Yeah, mostly hypo. Because when you just have a baby, you could easily dismiss this restlessness, maybe feeling on edge, irritability, or anxiety on you just had a baby and you're not sleeping, right? I did have actually a student come and tell me they had this, and they came in because their smartwatch told them caught the tachycardia. They felt a little off, and then it was the smartwatch. And then, of course, their mom had a family history of thyroid disease as well. So, depending on the patient, you can see them in either case. And then this bottom piece, I think, is really important. It's patient education. So, most of these people, so 70% will go after this hypothyroid state, it resolves. And they go back to euthyroid, everything is good. But next time they get pregnant and have a baby, a really high chance of them having this again. 80% resolve, 70% chance of reoccurrence, okay? And then say I'm one of the 80% that my the hypothyroidism resolved and I'm back in euthyroid, 50% of them will get hypothyroid in the next 7 years. Okay? So essentially the take home is you're going to monitor these people, right? Most of them will get better and they'll go to euthyroid, but the next time they get pregnant, you're going to anticipate this. Okay. Signs and symptoms, we got this already. Possible goiter, again, it's going to be non-tender, and then the labs are exactly the same. Treatment, exactly the same, right? Hyperthyroid symptom if needed, but really not giving them much, right? Especially if they're nursing. And then we give them levothyroxine if they have clinical symptoms and the labs indicate. Right. We're monitoring them for a year, so we expect the majority that they'll get better. This next one is painless silent thyroiditis. It's essentially very similar to postpartum, and then it's very mild, and then it typically resolves completely. Okay, so harder to test on this one, right? Because it's mild and it's not as common. But again, it'll typically resolve on its own. In the same, pretty much the same slide as postpartum. And again, they resolve in about a year. So that's it for autoimmune. There's overlap. We can follow the same trend. And we're going to talk about 3 other ones that are a little bit different. Okay, but luckily they present different based on a good history. Okay, so this is painful subacute thyroiditis. It's also known as de Quervain's thyroiditis, and you will see that or potentially hear that. The de Quervain's is used a lot, but this one is triggered by a viral illness. So they have a recent virus, upper respiratory tract infection, whichever kind, and it triggers thyroiditis. It's usually in your 30 to 40-year-old patients, females, of course, because it's thyroid, and it can resolve as early as 2 to 3 months, but for some it might take longer. Okay. So it's in the name. Painful subacute thyroiditis. When you do a physical exam on this person, they're going to have a tender thyroid. and it's going to radiate, just like when you have a sore throat from like postnasal drainage. A lot of times that pain radiates right to your ears, your lymph nodes are activated, that sort of thing. So that's very different than those autoimmune ones we just talked about, right? Painful thyroid. It's the first time that came up. Dysphagia, pharyngitis, right? Because is it the thyroid, or is they also have this upper respiratory tract infection? Low-grade fever makes sense. And then thyroid toxicosis, again, is usually mild, but varies per patient, and same with the hypothyroidism. It's the same trend. Labs make sense. The biggest difference on the labs is underlying. If you order an ESR, it's going to be elevated, right? Their body's fighting something. It's fighting something. It's viral-mediated thyroiditis. And then if you did a RAIU scan, this is where you would see the low uptake, right? That versus the Graves' disease where it's excess uptake. In this one, it's going to be that low uptake that we talked about at the end of class on Wednesday. So that's a key thing to differentiate your stuff. But again, what potentially gives it away? Get that good medical history, that good review of systems that you guys are doing in Clinicore, and they have a recent URI, or they are actively have a URI when they come see you and have a tender thyroid. So treatment, how do we treat a virus? Supportive care, right? Because it gets better on its own, right? So thyme, hot tea and honey, maybe a little whiskey, rest, hot showers, you can do those decongestants, that sort of thing, right? Same thing with this. So the first line treatment is just anti-inflammatories. Regularly, if you take them 3 times a day, a higher dose of aspirin than you'd expect. But first is anti-inflammatories, right? It's an inflammatory response. We want to treat the symptoms, which is that painful thyroid. Okay? They come in already on NSAIDs, or you give them NSAIDs and they come back and they call or come back and say it's still tender. Then you can add like a 7 to 10 day, up to 2 weeks dose of steroids, right? A bigger hit of that anti-inflammatory, right? So all those is just symptomatic treatment, right? Because we know that as the virus runs its course, thyroid cells are going to come back and start functioning. Beta blockers, if they're in that hyperthyroid state and they're not feeling great, and then obviously levothyroxine, if indicated. Usually it's really mild. 95% resolve completely. Now, there's another thyroiditis caused by bacteria, essentially like non-viral triggers. And this one, the name, so we have your painful subacute thyroiditis, right? Painful subacute viral. This one is, okay, yeah. Am I on? I hate the laptop, it's too small. There we go. All right, infectious suppurative thyroiditis is a bacterial or a parasite, and they're going to be much more sick. This is much less common. Usually they're immunocompromised, an old lady, they already have a history of thyroid disease, but maybe think the name infectious is worse than painful subacute, so you know that this is it's a bacteria. We need to do something a little more aggressive. So how do you think this person presents? Yeah, like fever, they don't feel good, and it's severe pain, and it's sudden onset. So the presentation is much more significant, and I'll show you a picture. Their thyroid gland is red and swollen. It's like you just kind of want to put a needle in it and tap it. It's so swollen. So they are uncomfortable. Again, it's sudden pain, tender, and then the thyroid area may be fluctuant. Okay, here's a picture real quick. Next slide. So that, to me, that is nothing about that history or the presentation says autoimmune thyroiditis, right? This is something different. It's red, it's fluctuant, it's severe, it's sudden, right? Infectious bacteria should be in the back of your mind. So you're going to do your labs. A lot of times these ones are going to, because it happens so fast, they're going to be in that hyperthyroid state. Their CBC is going to show signs of infection, and their ESR is going to be elevated. Okay? These people we do not treat in primary care. If they come and see you, they need to go to the emergency room because they need IV antibiotics and potentially surgical treatment. Okay. So everything about this is bad, right? It's the worst one out of all of them. Blood-plate physical exam goes with the name and goes with kind of the underlying cause. The last one is one that you're probably never going to see, but it has potential to be on the pants. elderly female who have usually history of thyroid disease, and instead of like a viral cause or bacterial cause, the normal tissue is replaced with like fibrous tissue, and so like scar tissue, and so it tends to, if you do a physical exam, the thyroid will be really hard, and then if it's encroaching on other, it's like spreading out of this nice little area where the thyroid should stay. They're going to have like signs and symptoms of compression, so dysphagia, difficulty swallowing, maybe voice hoarseness. So again, so you have fibrous tissue. They think it's IgG4 related, so they can have this fibrous tissue infiltration in other parts of their body too. But we're sticking just to the thyroid. And again, it's slow enlargement. There's adherence, fibrous adherence, and then compressions. I don't care if you know how to treat this one. If I decide to test you on it, it would just be recognition, okay? Because it's so rare and very unique population. Little old lady, but an old lady who has these signs and symptoms. I created this table last time. If you're a table person, it's all on one page, so after you study, you can use it. But again, I don't care about the treatment for IgG4, but that can be a helpful tool. Any questions about thyroiditis? Again, they present differently, yeah? And then is it fair for me to give you like a patient who's not pregnant? But it really would be hard for me to compare painless sporadic with Hashimoto's, right? So I'm not going to trick you on the test. You don't believe me yet. I won't intentionally trick you. All right, that's it for thyroiditis. We're going to talk about goiters, nodules, cancer, and emergencies, and we'll wrap it up today. So goiters happen in what? Hyper or hypo? Both, right? This is both. So that's why this one will be essentially pretty quick. So it's enlargement of the thyroid gland. It can be diffuse or nodular, symmetrical or asymmetrical. Iodine deficiency for sure causes this, right? The thyroid needs iodine to function. And then, of course, the thyroid disorders that we already talked about. Medications or causes of this. I don't go into them. And then obviously pregnancy. Everything changes with pregnancy. Okay. There's variety in our goiters. This one's really subtle. I think with the light, like I would have a hard time seeing it, but this one you see a little bit. You need enlargement. Again, that's why we touch the neck. We touch it. We have them swallow, right? This one you see it a little bit on the right side, and then of course this one is very uncommon. Typically, it's going to be in a population where there's a significant iodine deficiency. And they'll have, usually as a kid, they'll have like a big goiter, and over a long period of time, it turns into these multiple nodule goiters, and then they become toxic, and they produce their own. Each little nodule produces its own, like essentially its own autonomous thyroid gland, and so it spits out more thyroid, and it just sounds bad, right? This is just as far as globally what happens with those iodine deficient situations, right? The thyroid doesn't have enough iodine, so if it doesn't have iodine, it can't function. So you have low T4 and T3, increased TSH causes that, leads to that goiter. I don't go into the different iodine stuff, but just again, the scenario would point to iodine deficiency. And then this is just like it's an old map, but it's still just a reminder that we don't always see patients who grew up in the United States, right? So it's just to have this in the back of your mind, even though it's not the most common in the United States. And it's estimated that 1.9 billion people have insufficient iodine. That's a lot. So 8% of the population worldwide. Crazy. All right, physical exam makes sense, right? So you obviously identify on a physical exam. If you see a patient and they have a goiter, you need to check labs and then get at least an ultrasound. Okay, those labs are going to tell you if they're euthyroid, hypothyroid, or hyper. And then obviously the treatment depends on the labs and what the ultrasound shows. Okay, but if they're euthyroid, so their thyroid's normal, and the ultrasound start to display or display either hypo or hypo. Okay, that's it for goiter. This just kind of ties in what we already learned into just clinical approach to that. Then we have that toxic multinodule goiter. So again, these are each nodule kind of functions on its own and it secretes T3 and T4 unregulated. So if I have these multiple nodules that are secreting T4 and T3, how would the patient present? Hyper, yeah, typically hyper. And usually it's somebody who lived in the iodine deficient region, had a goiter, maybe didn't bother them at all, and then now it's starting to bother them because they're presenting hyperthyroid. Or what's going to happen if I get these nodules and they get bigger? It's going to cause some pain, right? There's only so much space to share in this region. So they might come in with different things. Okay. Labs make sense. This is what it looks like on the RAIU scan. Right? So increased activity gets darker and bigger. So nodule, nodule, nodule. And then obviously that's a nice pretty picture of it being removed. They don't all present as giant as that ridiculous photo I showed of the gentleman with all those nodules. They can be smaller like this. You definitely would feel that on exam. All right, so what do you think? So we know they have multiple nodules that are secreting T4 and T3 on their own, outside our negative feedback loop. How do you think, and they present in a hyperthyroid state, how do you think we treat these? Maybe meds, ablation, surgery, yeah. Okay, so we can give them meds, right? We like our beta blocker for that symptomatic treatment only, right? Give them our antithyroid meds, but for these patients, it doesn't usually shrink these nodules, right? They've been there for a really long period of time. And in the U.S., do we like to use these antithyroid meds long term? No, we don't, right? Because there's a liver toxicity. So a lot of times, we're using these until we can do surgery or an ablation, okay? So kind of supportive treatment until definitive treatment. On this one. Okay, so surgical. So surgical treatment is definitive. That makes sense, right? I have this multinodule goiter. It's toxic, causing tremor, tachycardia, potential AFib, all of these things. And there's pressure and cosmetic implications. Yeah, let's take that out, right? Surgery makes sense. Cool. Oh, and then we have this radioactive iodine 131, where we can ablate it, and it's also definitive. Great. There's two definitive treatments. Which one do we do? So let's look. So we would use ablation if there's a surgical risk, right? So this is somebody that happens, it's not when they're 20, right? This is much older when they're like in their 60s, 70s, 80s. So if they have congestive heart failure, if they don't, it doesn't bother them, there's no dysphagia, there's no cosmetic concerns, you can consider ablation. So, do you feel like you could decide on a test question? Is it going to be meds? Is meds definitive? No, right? Those are all before surgery or ablation. And current says definitive on both of these, okay? I wouldn't do this to you. But I feel like this one you can use clinical decision making. That's it for goiters. All right, we'll keep going. Nodules is kind of a lot, but really important. You will see thyroid nodules quite a bit, whether you catch them on exam or they have a history of nodules and you're just ordering their annual ultrasound. So 5% of adults will have a thyroid nodule, and as you get older, your chances increase. Obviously, most common in women. 87% are benign. I like that. That's good. Not actually follows with what you see in the clinic. But if you feel a nodule or a nodule is picked up on an ultrasound or some kind of imaging, you have to follow it up. Okay? Not just because 87% are benign doesn't mean you can just say that and see you again in a year, right? You need to work these people up. So there's single and multiple nodules. Pretty much the name tells you what's going on, right? A lot of times the single nodules are cysts, but again, you need to work them up. And thankfully 95% of single nodules are benign. And then multiple nodules, we have multinodule goiter, which can transition to toxic. And then you can see multiple nodules really in any kind of thyroid disease we talked about, okay? Including malignancy, which we'll get to. Non-palpable for sure. These these ones, they're usually found incidentally, whether they needed an ultrasound because of something else, or they had a CT or an MRI of their neck, and their radiologist is like, something's there. So again, half the time, it's not your great exam that's catching it. And again, most are benign. Here we go. I didn't even do that on purpose. So again, most are benign. A lot of people with thyroid nodules are euthyroid. So we'll go through what you have to do, but if they have signs and symptoms, you're going to check them and then treat them. They're less than 1 centimeter. That's usually a good sign. Not associated with lymphadenopathy, good sign. Again, you can have these with euthyroid, hyper, or hypo. Malignant nodules, it should be like kind of make sense at this point from my pathology history and things like that. But again, they have, it's either they shut up really fast. They have a personal history of radiation or some kind of radiation when they were younger. That's a risk. They have a family history of cancer, specifically medullary thyroid cancer, which we'll talk about a little bit here, and then again in lesson 6. And then they might have these like dysphagia, dysphonia, dyspepsia, these other symptoms showing that some malignant tumor or nodule is causing problems. And then young adult men, why is that? Why should that stand out for cancer? Most of these happen in who? Females, right? Young woman, no, I'm not as concerned. I still can't ignore it. Just because she's a female, I need to work her up. If I have a young male come in, I want to definitely, I'm a little more suspicious. Don't necessarily tell him you're cancer. No, you're going to work him up and then just make sure. Here's a table from Current. It just talks about the different nodules. Like that. All right, so we do a physical exam on a female, and we feel a single nodule. What should we do?
Work it up.
Yeah, so how would we work it up? What are tools do we have in our pouch? Labs? Perfect. What else?
Ultrasound.
Ultrasound. What else? That RAU scan, right? Or biopsy. Yes, perfect. All right, so there's a nice specific order of things. So we have filled the nodule, we're going to go straight to our lovely TSH in a minute, right? TSH and free T4. Again, all they're coming in is the nodule. They have no signs of hyper or hypo. So we get our labs. If TSH is low, we're going to do an ultrasound and an RAIU scan. If TSH is high, we just do the ultrasound. Okay? So again, if it's low, that indicates what? Hyperthyroid. So that's where we're going to do both. If TSH is high, it's indicating hypo, right? Pituitary's working, problems in the thyroid, we're going to just do the ultrasound. Now, the ultrasound is going to tell us a lot. Is this a cystic nodule? Is it have abnormal features? It's going to verify the size and all of that stuff, okay? And it's easy to order versus that scan. Here's that blown up. Understand this. You guys already guessed it. So again, it kind of this builds on it on lessons from earlier. Yeah.
For low TSH, does that mean both?
Both. Good question. You're going to do both. Yeah. Just because in that the scan, the RAU scan is really helpful with those cold and hot nodules, especially in thyrotoxicosis, the hyperthyroid state. So, and I have animations. All right. So, what does it look like under ultrasound? Okay, always go to the same. So we have this one is a cyst versus the lower one is a thyroid nodule. What stands out? I know you guys aren't pros at reading ultrasounds, the thyroid gland, but what stands out about this? Yeah, so it's solid, and then there's this dark spot, and then maybe there's this halo around it. Don't worry, radiologists get paid big bucks to sit in their dark rooms and tell us what's going on. So they will tell us what's going on, and they will these shouldn't be surprising, but signs and symptoms of malignancy, right? Irregular margins, for sure. Microcalcification, if anything is complex, even though it's a cyst, that's concerning. If it's extending outside the thyroid gland, don't like that, right? Taller than my gesture, I don't remember that, but and then diameter over a centimeter. So even if it's benign period and it's large, that would be a red flag. luckily, in real life, they'll tell you, they'll be like, hey, it's a complex cyst, recommend FNA or recommend this. Or it's benign, recommend imaging every year, or every 2 years, or never again, okay? So usually radiology hooks you up for that. All right, so we did ultrasound. This patient, our patient was euthyroid, we did our labs, and they were normal. We do an ultrasound, and it shows a suspicious nodule. So then we're gonna go and do the biopsy, right? Fine needle, aspiration, biopsy, ultrasound, guided. So we can find out if this is malignant. There's just a little more details outside of just the ultrasound of why you would do an FNA, right? Benign but greater than 2 centimeters. They had a history of that head. This is the third time head and neck test radiation just came in to play. Lymph nodes, you had clinical suspicion, right? To go along with that history, then you would order this FNA. This is not something you memorize, but it just shows you like there's some thought. We don't just fine needle biopsy everybody, right? It's ultrasound, all of these things go into it, and then once that biopsy is evaluated by the pathologist, they categorize it, right, into what kind of like staging essentially. But this is not something you need to know. Just know that that's what happens after you order your FNA. All right, so what do we do next? So management for benign nodules. So again, that's what I mentioned. Usually there's maybe annual ultrasounds every 2 years, and so you would do that. If you do the FNA biopsy and then it's cancer, then we're talking to need to do surgery or ablation or that sort of thing, right? And then obviously levothyroxine if indicated. Right? We treat the hyperthyroidism if indicated. Any questions? Cancer. All right. So there's 4 types of thyroid cancer, and luckily papillary, the most common, is also the least aggressive. Okay. So again, most of the time those nodules, thyroid nodules, are benign. But if they are malignant, most of them are easily treated, treatable, and not super aggressive. You will see, you might even know a friend or a family member who's had thyroid cancer. You'll see in the patients, they have a nice linear scar. They had the surgery treatment right there on their neck. Military, you can have thyroid cancer, you get it, they treat it, and you stay in. Okay? Obviously, as long as it's papillary, everything goes well, or maybe follicular. There's a term I added, the differentiated thyroid cancer, or DTC. That's a term you might see in clinic. It's not going to be on the test, but it includes follicular and papillary. So we're going to dive into each one briefly. Papillary, most frequent, least aggressive. Usually a single nodule. Again, exposure of radiation, that would be a red flag. This one absorbs iodine. Why is that helpful? Yeah, for the scan, and then also in treatment. So if I have cancer, I probably want to cut that cancer out, right? Like I want to get rid of it, right? And luckily, people, especially with papillary thyroid cancer or even follicular, you do surgery, you remove the thyroid, either total or a sub or partial thyroidectomy. If you know your cancer absorbs iodine, what else could you add to it? Yes, the radioactive 131 ablation. Perfect. Yeah. So, and again, these people do really well. Follicular, second in line, absorbs iodine as well. Unfortunately, this one's a little more aggressive because it does mets to different areas. This one, medullary thyroid cancer. This one probably is like on your patient's radar because the GLP-1s, you can't give GLP-1s to people with a history of medullary thyroid cancer. So I feel like that's why it's maybe on people's radar. Not super common. It's associated with multiple endocrine neoplasms, or MENs 2 and 3. We'll kind of tie back into that in the 6th lecture. But this one arises from the parafollicular cells in the parathyroid. So they actually might present with like flushing and diarrhea, which would lead you to check their calcitonin, and then the calcitonin would be high and be like, hey, maybe they have thyroid cancer. but not super common. When I do the review, I'll kind of tell you what you can focus on. But yeah, and then our last one is our least common 1%. This is your anaplastic blood, so it's very aggressive. This happens fast, so it's not a gradual thing. And they almost present like that Rydell's thyroiditis, that IgG4, where it's like hard. Only this one's it's overnight, maybe, or it feels like overnight. It's happening fast, and they do not do well. Hoarseness, dysphagia, and it mets quickly. Luckily, though, it's aggressive, but really, really rare. All right, so through 4 thyroid cancers that you presentation should make sense, right? We hopefully feel it, or we catch it on incidental imaging, or they come in not necessarily, we don't feel anything maybe on exam, but they have dysphagia, where their voice is changing, they have hoarseness, they have a history of head and neck radiation. Something sets off our radar to be like, this could be cancer, I'm going to evaluate it further. Lymphadenopathy, right? All of these are all red flags. Labs, I just go ahead and just put FYI on this one. When I looked at it, today's it's a little busy for me, but just know you're going to do labs, and that's pretty much it. Calcitonin is related to the medullary thyroid cancer, and then, yeah, that's just FYI on this guy. Okay. Imaging, this should make sense, right? Ultrasound. If you had a suspicious nodule caught on like a CT or MRI, are you good to go straight to an FNA? I need you to just know always, if you have any kind of weird incidental finding on an imaging, you need to do a thyroid ultrasound. That's like the best way to determine if you need to go the next step. I think that's on a slide and I just breezed over it, but anyway. Ultrasound, you might not just be looking at the thyroid, you might be looking at the chest and abdomen, you might be doing a PET scan, right? Because this person has cancer. So don't memorize all of this. This is endo, not heme. So. All right. Treatment of choice is surgery. Because we can't, real life, the patient might decide against surgery, but the majority of the time you'll see people get surgery. So in real life, it matches the textbook. Plus or minus that radioactive iodine ablation for the follicular and papular. Why? Right? Because it absorbs iodine, we're going to take advantage of it, so you may see people get bold. For medullary, it's only surgery, and anaplastic, it's only surgery, right? Because it doesn't absorb iodine. This just explains that post-surgical iodine 131 that could, if for some reason they did surgery and they missed a little bit of tissue, this will kill that for the follicular and papular. Okay. And then thyroid replacement therapy, you guys, that's like no surprise there, right? We took out their thyroid, or we ablated it and took it out. What do? Give them levothyroxine, right? Levothyroxine all day. The big take home here, I don't think this is pants-worthy per se, but if you had someone who had thyroid cancer and you see them for follow-up, their TSM, they're essentially going to really aggressively treat them. They really want to suppress that TSH, and that's just because of the post-malignancy treatment. So it's a little more aggressive. So remember that TSH, the goal when we give someone levothyroxine, that sweet spot is 1 to 3. TSH between 1 and 3. These people are going to be 1 or less than 0.5, so they're going to be really more aggressive, and that just has to do, depends on the type of cancer they had. An endo usually manages that, but again, that's why it says your focus is to suppress the TSH, so they usually, that TSH level is a lot lower. Okay. And then this, because you had the surgery, doesn't mean you're done. These people are followed regularly, especially for the first 5 years. And because, well, what do they have? They have hypothyroid. Right? All right, we can stop there, and then we'll move into emergency thyroid stuff in some cases. You guys get back. So I guess 5 till.
So much vegetate. Hell
Yeah, no.
yeah.
Yeah.
Doggy down.
This isn't the last matter.
I'll be on.
I didn't know this was last year. I didn't know it. I would have been larger if I knew. I was already having 3 pounds. I didn't know it was office. Yeah.
Yeah.
smells so good. What is that? You bring your mouth over here? I can give it. I have a especially if you can save anything. You can take advantages of the end of the day.
Is there anybody that would be very much opposed to starting infectious disease as soon as we're done with endo? We would work through lunch a little bit, but we'd like to be done early.
Send it. Please do it.
If you don't have, so if you have your computer, as we do the transition to infectious disease, go ahead and pull it out, log in, and get ready to do it at noon. If you do not, then don't worry about it. Just do the quiz on whatever device you have. Just quick show of hands, who does not have their computer? All right, so that's the majority. The purpose is they want to stress the system and test it. So we'll still do that at noon. But if no one's severely opposed to it, then we'll roll right into infectious disease. It'll push into lunch, but then we'll be done right afterwards. Or if you have a serious thing, DM me on the side, and then I'll make a decision. You don't want to tell me.
I feel a huge phone in my life. Yes. I would have got sausage.
Homemade bagels.
Homemade bagels. My wife made a
Yep.
No study. No study or yes or not. I kind of realized I have a busier schedule than I thought, so depending on how long I play tennis in the day, I don't know. I don't know what our tennis schedule is / movie.
Show me the We'll take a key of cocaine quickly.
You can just not do movie. And go to the movie with me.
But I'm saying, like, if depending on what you do tennis and stuff,
Do tennis later, and I can hang out with Tatum for a little while. We're not really. Yeah. What? Yeah. Yeah. That's pickleball courts right next to my house. Broadway. It's like literally one of the shows. You can show up, but you have like it's obviously reserved. I don't know. I think it's gone. The only time I played here.
Not all you know. You're pushing outward. Pushing that outward.
But the hand was over here, one hand was in here.
But it was pushing me
Jalapeno.
So it was pulling the arm like that, but it was saying pushing out like that.
This is out.
So when you push the arm that way, it doesn't listen. But when you push it that way. Out. Out.
Alright, so we're gonna mention the non-physical avoiders, the overlap and all the things. Now we're gonna talk about thyroid emergencies. There's two. One's hypo, one's hyper, right? So that's helpful. We'll talk about treatment and how they present so you don't miss it. Okay, so the first one is thyroid storm. You have to guess, is that hypo or hyper? Hyper, right? It's a storm. It's like excess thyroid hormone instead of excess rain and hail and stuff, right? So thyroid storm is extreme hyperthyroidism or thyrotoxicosis. This is extreme because we're in emergency mode, right? They are not coming. They're not coming hopefully to the PCM because they feel that bad. Thankfully, not a lot of people get this, but if they do, it's usually more common if they have a history of Graves' disease. High mortality, unfortunately, too. This is scary. Precipitating factors matter, right? So if they have like a stressful illness, surgery, the main one is if they discontinued their meds, right? So if they're on anti-thyroid meds and they're poor compliance or whatever reason they stopped their meds, and then they also have a cold or some kind of UTI or some kind of stress to the body, so you have two things, then that can cause it. Amiodarone induced thyrotoxicosis is the most common, and that so they would have like a history of amiodarone. But that one's tricky because it causes bradycardia. Anyway, no, I won't go into that. But anyway, so that is technically the most common. But a lot of times it has to do with the stress of the body, some kind of surgery or something that caused it. Okay. Signs and symptoms. So we have the metabolic knob, but we're turning it way up. So they have a fever, a high fever, right? Because we know thyroid has to do with energy and temperature. So with Graves' disease or any kind of hyperthyroidism, they're hot and sweaty. These people have a really high fever. They're sweaty. They have tremors. They're restless. They are sick, right? Sick, not sick. This patient is sick. Vomiting, diarrhea, and then you have all the cardiac pieces. The cardiac stuff should make sense, right? Because hyperthyroidism, you have the risk of AFib and all these other things, and so it's more extreme. We're talking heart failure, atrial fib, heart attack, cardiogenic shock, right? So not good stuff. There is at the bottom this Birch-Wartowski scale, and essentially you get points. Like, do you have the temperature? Do you have cardiovascular disease? What's your heart rate? Just heart failure. So you get points for all these different factors, and then that points you into, like, confirms thyroid storm. I'm not doing that to you on the test, but again, there's you could use that as well. How do you? So if they're showing up in the ER, what kind of treatment? Who's going to treat these you'll need to monitor them. We might have talked about this in farm. I think you had farm between our Wednesday lecture or not, but they should align pretty well. So the first thing you need to do, obviously, is recognize this person has thyroid storm, and then you need to understand treatment. So the treatments, we're going to do anti-thyroid meds. So the PTU or methimazole, we need to do that right. Why? Because they're in the super hyperthyroid state. We need to stop the synthesis of T4. Okay. PTU is preferred in pregnancy and in thyroid storm because it blocks the synthesis and the conversion of T4 to T3. Okay, so just to, but again, I'm not gonna like quiz you on those two differences, but just so you know, PTU is what we like, and now you understand why. You can tie that into farm, layering, how about that? IV propranolol, right? Because again, they are restless, tacky, all the things, and it helps with all those cardiovascular symptoms. Okay, but it doesn't treat the underlying condition, right? That's just still symptomatic, just like it is for Graves or any other cause of hypothyroidism. Then we can give iodine, but we have to wait usually like an hour after we give them anti-thyroid meds. Why do you think?
Drug interaction.
So iodine stimulates thyroid gland, right? We need iodine for thyroid function. So if I have, I'm like, oh crap, this person has thyroid storm, we're admitting them, I know they need PTU, let's give them iodine. No, because you don't want to activate the thyroid gland. You need to calm it down first with their lovely anti-thyroid meds or PTU. Give them their propranolol so they feel a little bit better. And then after that, if we calm down the synthesis, then we can give them iodine. Okay? And then steroids, right? Steroids can help as well with conversion and anti-inflammatory. But essentially, these people aren't just like on IV meds for a long period of time. We need to do surgery or ablation, right? We need to. If they're a patient who decided that they're on Graves, they have Graves maybe, and they decided they want to do medical management, but it's not working. Now they're in thyroid storm. They're admitted. We need to take care of the problem through ablation and surgery. Does that make sense overall? So again, it's ongoing. They're admitted. Endocrinology, they're all coming in. You got to cool this patient. Respiratory support, all of that stuff, right? And then there's again definitive treatment is what? Ablation and or surgery. Okay, opposite end. Mixed edema crisis. So this is severe hypothyroidism. It is also life-threatening. Okay, this is a sick, scary patient. Triggered by stopping their medication, right? Usually it's an old lady who stops their meds, maybe they forget, whatever, and they stop it and that can trigger it, as well as an underlying infection, some kind of stress or trauma. And I think it's an interesting cold exposure can trigger this. If they're out cold for a long time, that could trigger it again. So it wouldn't ask you to say what is hypothyroidism triggered by, but it would be part, in a question, it would be part of the story. And then, I have it right there. Most common in elderly women who has some cardiovascular trigger, some stress to the body, or they stop taking their medication. Technically, you can diagnose somebody with hypothyroidism if they didn't have access to care for a really long time. This could be the original presentation. But if you have access to health care, you really can. Hopefully. Again, think hypothyroid, but very extreme, right? I'm confused, maybe even comatose. They call it the psychosis or myxedemia madness. Seizures, lots of electrolyte abnormalities, hypoventilation, hyponatremia, hypoglycemia, fluid retention, right? These people are definitely have the edema, the puffy eyelids, the puffy face. What is a frowsy hair? Yeah, it's like it's disheveled. It's like dry and unkept, untidy. So this is the classic picture of mixed edema crisis. So maybe it was a color. You probably see some yellowing of her eyes, clear eyes, with the puffy face. They say puffy eyes. This frowsy hair, and then she's like a dull, apathetic appearance. Looks like she's in her little robe, this lady probably is not taking meds or maybe has some underlying cardiovascular disease at the same time, and she unfortunately comes to your ER in this mixed crisis. So we can't just give them Synthroid and say come back in 6 to 8 weeks. No, we need IV levothyroxine, right? IV and supportive care, right? Because there could be bradycardic, hyponatremic, hypoglycemic, hypothermia, so their temperature is really low. So we need to give supportive care and the IV Synthroid. So very overlaps with thyroid storm, right? As far as we're more aggressively treating, monitoring IV and still oral meds. Mortality rate is unfortunately high for these folks. And then again, hyponatremia is something we have to deal with. Questions on those? Okay, that's it for thyroid disease. We're going to do some clinical correlation, so please participate. We'll do some check out learning next time on Monday. And yeah, all right. So thyroid Stewart, chief complaint. So she thyroid Stewart is a 35-year-old female with palpitations for 3 to 4 weeks. Okay, pretend you're not an endo. What's your differential? What are some differentials for palpitations? Hyperthyroidism, I like it. What else? Anxiety, what else? Caffeine, ST, all the things that cause, are you learning tachycardia and cards? Yeah, all those cards things, right? But we're in endo, so. All right, so let's get more of a story. She reports fatigue, heat intolerance, nervousness, shaking, and irritability. Her hair and skin are more oily than normal, increased frequency of bowel movements. Okay, what are we thinking? Hyper or hypo? Still hypo. Okay. Not the additional history didn't change a thing. Oh, and that review of systems that you're trying to remember in Clin4 came in handy because through your review of systems, you realize she reports she also has a mild URI. Started about 2 weeks ago. It's still lingering. She's still struggling with it. She thinks it's improving. She has that as well. Okay, helpful. And the family history of thyroid disease. Her mom takes it. She's not sure what it is, why, but she knows she takes a pill. Okay, what do we do next? Good history. What do we do next? Physical exam. Okay, so vitals. So she's sick, not sick. She's well developed, well nourished, sweet, no acute distress. And what do we think of her blood pressure? 139. She's 35, but she's also having palpitations. Maybe it's isolated elevated blood pressure. She's tachy at 110. Temperature's okay, and respirations are on the high side. Thyroid gland diffusely tender. That's very unique, right? A very unique thing happens with that. Tender, but does not appear enlarged. There's no erythema or fluctuance. That's helpful to know. No lymphadenopathy, no lesions. Rest of that good exam that you did is normal, except for her heart rate. What do you want to do next? I gave you the answer. Labs, right? History, physical exam, labs. What labs? Yes, TSH for sure. T3, T4. Why T3? Yeah, because this is a hyperthyroid patient. If she was hypo, I would say all the T3s, reverse T3s, anti-T3. Yes, all of those. So TSH, perfect. So your labs, TSH is low. 3 T4 is all you get back so far, and that's elevated.
I'm using Notion AI to track.
Okay, and the rest of her labs are unremarkable. She's not pregnant, no urinalysis. So, what do we think? Overactive or underactive thyroid? Over, yeah. You guys can't sneak anything past you today. All right, so now what do you want to do? We won't probably do maybe a few more labs. We definitely need that T3. What else can we do? Yeah, we can do the scan. Yeah, what else? What's another blood test if she has a URI that can help point us in a certain direction? T3, CBC, yeah, ESR, yeah. So the CBC is usually higher in that bacterial infectious, but it could be high in this one too. So we get our T3 back, ESR, we order the scan, the ultrasound, we've consulted endocrinology. T3 is high, we get both, total and free. Your lab is fancy. Your antibody panel is pending and the ESR is elevated. your ultrasound's pending, but you guys have a connection in radiology, and she gets her scan right away. And it shows low radioactive iodine at 1%. Normal is 10 to 30. She's at 1%. If you don't remember the name, do your best. Viral, I hear. Viral what? Thyroiditis. It's painful, right? It was painful. So painful, subacute thyroiditis or de Quervain's. If you like de Quervain's virus, use that. So thyroiditis most likely is viral cause, right? So, how do we treat this? It's a virus. The virus infiltrated the thyroid. It dumped out. There was a passive dump out of T4 and T3, mostly T4. She's in this hyperthyroid state. She doesn't feel good.
It says.
Yeah, we can give her some propanol because she's symptomatic. What about to help with that virus, what's going on in the thyroid gland? NSAIDs, yes, NSAIDs. Or aspirin, if that doesn't work, prednisone, propanolol. Follow up in a few weeks. We need to track her thyroid function. 4 to 6 weeks ideally, but we want to see her back a little bit sooner because she's symptomatic. What do we tell her? What should I tell her? You're going to feel like this forever? Do we need to send her for a surgery and ablation? No. What do we expect to happen? Yeah, normalize. She might get a hypothyroid, but how long will she be hypothyroid? Forever? Not usually, right? 95% of the time you're going to get better. So look, you guys got patient education in there too. You guys are on your way. All right, metabolism is a 15-year-old female. She's coming in for a sports physical. She feels great. No concerns. All right, what's your differential?
Huh.
I don't know. Yeah, okay, let's keep going. All right, past medical history of radiation therapy at age 6 for enlarged tonsils in her homeland of Thailand. Hometown in Thailand, excuse me. Meds, none. Vital signs, stable. We do a thyroid exam, it's firm. There's a fixed or a fixed nodule on the right lobe, 2 enlarged anterior cervical lymphadenopathy, or lymph nodes, excuse me. Thyroid's non-tender, no erythema. What do you want to do? You want to say follow up in 1 year? Here's your sports physical form? No, okay. So we want to do some labs first. I know you're getting extra credit, you can do it all. Labs first. TSH and free T4 or normal. Now what do we do? So there was, ultrasound and scan or just ultrasound? Start with ultrasound. It's right there. I need to fix my animations. Okay, so you do an ultrasound and there's a fluid-filled complex cyst. 1.4 centimeters. Are we done? No, what should we do? The fine needle biopsy, right? Okay. So the biopsy, we got to check for cancer, right? So she had lymph nodes on exam. She has a complex cyst. It's larger than a centimeter, and what? That history of radiation, right? She might feel fine, but we can't just let her go on and see her in a year. So, assessment: a thyroid nodule with lymphadenopathy, euthyroid on labs, ultrasound shows there. We put our order for FNA or FNAB. We want to see her back as soon as like a few days after the biopsy. Honestly, you're probably going to call mom and give her the results, and then some education about thyroid nodules. Okay, extra credit. If say the FNAB comes back positive for cancer, what's the most likely cancer this person has? What is it?
Papillary.
Papillary. You'll get there. Papillary. I don't like those most common questions unless it's drugs. This papillary cancer. All right. So this is gonna be you guys this weekend in the sun because you don't have a test on Monday. You have me. You're stuck with me at 8 a.m. But yes,
Took me a second. I was like, I remember what
heard
she
it
said.
went well, and then I'll see you guys come in.